Welcome everyone. I'm Dr. Snyder, and I'm just going to cut to the chase, not go into any big speech. I'm pleased to introduce Dr. Clifton Schermerhorn, who is a board-certified psychiatrist, neurologist, and pain specialist, who is on staff at the Community Coastal
Coastal Community Hospital.
Coastal Community Hospital in Santa Ana. And without further ado, let me just introduce Dr. Schermer.
Hi, everybody. Howdy. Hello. Thank you, Dr. Snyder, for the nice words. I've known Dr. Snyder for years. We kind of talk to each other over the phone and through notes and whatever. But we're going to talk about something really interesting today. Not only interesting, but very complex. So I'm going to, since I learned that I was going to give this lecture, I did a lot of studying about this. And I'm telling you, it taxed my, experience and, education. Because, Dr. Snyder and I are getting towards the end. Well, I don't need to speak for Dr. Snyder, but, my organic chemistry and my biochemistry is 30 years old now, and so much has changed. And this is so apropos because my daughter is just about to go to medical school and she's taking organic chemistry. And I had to ask her questions about this thing. What we're going to talk about today, I've titled the thing, Not for Human Consumption, okay? And we're going to talk today about K2, spice. This is a really, really dangerous drug. This is, and I heard it was best described as crystal meth and LSD combined, and 10 times stronger. This is a drug that is described as faux or fake or legal marijuana, legal cannabis. It is nothing like that at all, okay? I don't know where that name came from, but it is not marijuana. It's not even related to marijuana, okay? Can I write on this board over here?
Let me grab you a marker.
Yeah, because I have to write in order to talk. I think there's an Italian, how Italians have to talk with their hands, I have to write, and I'm going to be writing some things that, wait a minute, maybe this is it. Take two. Spice. This is actually MDPV. And again, so that I don't just talk to Dr. Snyder, okay, and follow this. If I get too complicated, just raise your hand and say, I don't understand, and I'll try to simplify it if I can. Because remember what Einstein said? Einstein said, you don't know anything unless you can make it simple, right? So we're going to try to make it really simple. This is a really complex substance that we're going to try to make really simple. This thing started with a substance called cat, okay, which is an African shrub that the indigenous people there chew, and it makes them high, okay? And some guy back in 1910 identified this and started messing with the substance. This is actually methylene dioxypyrovalerone. That's the substance. That's the base substance. Now this is a designer drug because this, what they did was they isolated the substance in this that was hallucinogenic, and they called it, that substance was cathinone. Okay, cathinone is a type of amphetamine. Okay, and so what they did was and this is kind of interesting. This is the thing that's really interesting, because this hooks into a whole lot of stuff that they're doing today, including including the performance enhancing agents that you see, Lance Armstrong. Basically what there are is there are pharmacologists and doctors out there that are constantly trying to beat the system. You see, in 1906 there was a thing called the Harrison Act. And the Harrison Act, before 1906 you could use anything. Nothing was illegal. You could use anything. It was all legal. Heroin, you know, opium, everything was legal. Okay, there wasn't any heroin then. Heroin was actually, did you know that heroin is actually, it was actually produced by the Bear Aspirin Company as a cure for opium addiction. And it works really well. And then methadone was developed in the late 40s as a cure for heroin addiction. And it's even more addictive than heroin.
And it works really well.
And it works really well, yeah. I know very few methadone maintenance people that aren't also using heroin, right?
Exactly.
So what they did was, there became a cottage industry after this to produce something that wasn't illegal. You see, when they made the act, and when the federal government makes laws, they say, this substance, and I'll just draw you a picture of it, because let's say it looks like this. Okay? That's what the chemical structure looks like, okay? I just made that up. I mean, it's close. I drew it from my daughter, and I said, this is dimethyl chicken wire, you know? Anyway, so what they do is, if you have a substance like this, the government says, that's illegal. You can't have that. That's Schedule 1 drug. You guys know about the schedule? Schedule 1, 2, 3, 4, 5. Schedule 1's illegal. You can't use them. Not therapeutic, okay? Marijuana is in that group for the feds, okay? Heroin's in that group, right? So the government says that's illegal. So what they do is they get a pharmacologist to come in and put an OH there. Now it's not illegal. What does that do? I don't know. What's the consequences of taking that orally? I don't know. What are the long-term consequences? I don't know. Does it cause permanent damage? I don't know. Is somebody gonna, in order to determine that, you'd have to go through the animal studies and then the FDA, whatever approval. Who's gonna pay for that? Nobody, okay? So, if you take this, you're experimenting on yourself. And it causes terrible, awful things, maybe. But we know it does, okay? We know, remember what I said, this has the effect of a combination of meth and LSD. So this is really dangerous stuff. We don't know. And in fact, the guy that actually made this, okay, said, he was from Cornell, and he said, this is not for human consumption. His words were, this is never to be used by humans. This is literally poison, you know? And they're using it. They sell it in, or they have up until last year, in head shops as pesticide, as plant food, as incense, as legal cannabinoid. They snort it, they smoke it, they shoot it, they put it up their butt, okay? This is really dangerous stuff. It causes major problems. And the reason it does, let's go into the physiology of this. Here's your brain. It weighs about 3 pounds, a lot smaller than most people, okay? Way up in this area here, there's a thing called the nucleus accumbens. Okay? The nucleus accumbens is the pleasure center of your brain. And it responds to dopamine, okay? Let's look at, you guys know about neurotransmitters? Let's look some neurotransmitters. Dopamine, serotonin, HT, norepinephrine, GABA, okay? These are neurotransmitters. These are chemicals that are made by your brain to run things. These are the chemical messengers, okay, that are made in your brain. What these drugs do is play games with these. They cause greater or lesser amounts of these transmitters to be produced. These are normally occurring in your brain. When you take these drugs, regular drugs, regular FDA-approved drugs, and these, you're messing with these. And these can be real dangerous if not in the right balance. For instance, dopamine. Dopamine is the one that gives you pleasure when it hits the nucleus accumbens, okay? If there's too much dopamine, what do you have? Schizophrenia. You get crazy. You ever seen a person with Parkinson's disease? They don't have enough of that in the extrapyramidal system. So they get real stiff, okay? So what does the doctor do who has a patient with Parkinson's? He gives them dopamine. Say that. He gives them dopamine. And what's the side effect of the dopamine? Makes you goofy, makes you crazy. You see things, you hear things, So it's got to be just in the right amount, right? Serotonin is another one that is responsible for depression. You've heard about the SSRIs, the selective serotonin reuptake inhibitors. Want to hear a cool story?
Yes.
How they figured out that these drugs were good for depression? What they did was they had a group of rhesus monkeys. And they found that in the rhesus monkey group, there was a subset in the rhesus monkey group that were real happy and well adjusted and adapted, and they felt good. And then there was a small group in the bottom that were depressed and anxious and withdrawn. Okay, so they took samples from their brain and they said the monkeys that are withdrawn and depressed, they don't have enough serotonin. So the scientists said, what? Let's give them more serotonin. So they did. And guess what happened? They died. All of them died. Because serotonin doesn't work. It works differently in different parts of the body. Who knows best where it works? Your body. If you give it outside, it's going to work in it works on vasoconstriction, heart rate. It works on your respiration. It works on your kidneys and your liver in different ways. So they had to selectively increase the serotonin. But they didn't give serotonin. What they did was they found a drug that decreased the reuptake of it. So they called it the selective serotonin reuptake inhibitor. Selective being just in the brain, reuptake inhibition. They found a drug that did that. They didn't put serotonin in there. They let the serotonin that was there stay there longer was all, okay? And it still has some side effects, doesn't it, okay? Norepinephrine is the same thing, the same way. We used to have the TCAs. Remember the TCAs? You guys remember those? Or tricyclic antidepressants? Dr. Snyder, remember those? What was the problem with those?
Sedation.
Side effects. Lots of side effects, okay? Because they weren't selective. Yeah, sedation, dry mouth, blurry vision, constipation. And remember giving these drugs, that patient had come in and you give them a tricyclic and it'd constipate them, dry their mouth, give them blurry vision, and make them lethargic. Oh gee, I'm going to take that drug more, aren't I? Right? Yeah, give me more of that. You couldn't keep them on it, So they did selective reuptake of serotonin and selective reuptake of norepinephrine, not putting that in, but just keeping it there longer, and the same thing with GABA for sedation, like with the GABA reuptake inhibitors like Buspirone and whatever. Okay. So basically, what happens is that when you make a designer drug, you're messing with these. And what do? What are they doing with those? I wish we had the video up here, because I want to. There's a great video that they're not able to put up here, but the way you think of it is like this with these designer drugs, with this designer drug, this class of designer drugs right here. Okay, it's like a faucet and a sink. Think of a faucet and a sink, and the faucet is dripping a normal amount of dopamine, norepinephrine, and serotonin. It's dripping that amount, right? if you take crystal meth or you take cocaine, what you're doing is you're putting the plug in the sink so that it builds up, doesn't it? Okay? And that causes a problem because it's building up. If you take meth, amphetamines, what you're doing is you are unplugging it, but you're causing a greater a flow of neurotransmitters. And if you take this drug, or any combination thereof, any perturbation, what you're doing is you're increasing the flow and putting the plug in the sink. And that's causing tremendous increase in activity of dopamine, serotonin, norepinephrine, and GABA. GABA-aminobutyric acid. Would that be bad? It is horrible. The people that take this drug, if you go through it and look at some of the, the interviews that they have with people, it says it's like being in hell. This is the guy, this is what happened to the guy in Florida who took this and went tried to eat somebody's face off.
Right.
They hallucinate. This actually causes a delirium. Delirium. This is delirium. Whenever physicians hear that word, we freak. Why? Because this is brain failure. This is you have to find out what's causing this and change it, or you die. Right? This is delirium. This is what you see in DTs. This has to be treated, or you die from this. Right? So basically, what we're causing when we're using these designer drugs, spice, or any perturbation thereof, is a iatrogenic delirium. And people die from this. Lots of them. There's lots more people dying now. Again, what this is, this particular bath salt or any perturbation thereof, and again, why am I saying this? Because that right now isn't what's out there right now. It's something like that, but we don't know exactly. And in order to determine this, we have to do, when they do drug screens, you ever wonder, we always assume somebody's got a drug screen. What happens when you do a drug screen? Is there a question?
Yeah, I just wondered, is any level, any dose toxic, or does that have to get to a toxic level?
I don't know. We don't know. How are you going to tell what the toxic dose is? It's never been tested. Would they let us, Dr. Snyder, would they let us test this on humans? No. There would be no way the FDA would allow us to test this on a human. We can't even get approval to test it on the lab animals. You know, it's so powerful and so malicious and nefarious. You know. Yes.
I'm sorry, what about, just kind of an off-sided question, or offhand question rather, what about people that are using it and come into our clinics to get clean and sober, and they're on this?
Okay.
Is there any way we can test for that to find out?
It's
There's gotta be
difficult,
some kind
unless
of
they tell you it's difficult, because when they do the spectrophotometry on this, and that's how they do drug screens, you know, they do spectrophotometry, they shine light, different kinds of light, on the substance, the substance in question, and it shows up in as different wavelengths by the side chains that are on this. Okay, it'll show up. It'll spike here, and from that they can say, oh yeah, this is cannabinoid, or oh this is cocaine, or this is meth. Because we know what those look like. We don't know what this looks like. And when we find out, what happens? What happens to the guy that's making it? He changes it.
He changes it.
So they do the spectrophotometry and say, we don't know what that is. We can't tell. We can't figure out what that is. So what the guys that Armstrong, he had a whole team of guys that were just doing that. Basically, what would happen is they would find out what the spectrometry was, and then they change the molecule. Really dangerous stuff, you know. So very difficult thing to follow, because there are labs out there that do nothing than try to modify this to beat the system. They don't want the feds coming in on them, so they change the side chains, and who knows what the result is. We don't, you know. Might be even more. And the thing is, some of these, going back to your question, you would, you know, this is advertised as synthetic marijuana. Nothing of the sort, okay? This is would this be addictive? Extremely addictive. Why? Because when you hit this nucleus accumbens real hard, it remembers. And it permanently changes that thing. There are surgical centers in South America that will go in and surgically remove part of the nucleus accumbens to overcome the tremendous addiction. You guys know how powerful addiction is with cocaine. I mean, there are people that will go to bankers that will bankrupt their bank, and people that will steal, that will do all kinds of crazy things just to get that high again, right? This is a very powerful addictive, very powerfully addictive substance. Okay. I mean, just as an editorial note, I know there's a lot of people, and this is part of the problem with this, is there are a lot of people, we're getting more lax with our marijuana laws, right? I don't think that's a good idea. Because what happens, I have people now, Dr. Snyder, you too, they come into my office and they say, I don't want any psychiatric drugs, but I need marijuana to get me better, okay? There was just an article out, and if you guys are interested in this, really interested in this, I want you to go to a website called MedPage Today. Okay, it was, and basically what they do is it's the latest stuff in medicine, and you get to do CMEs for it too. They give you 0.25, and there's 10 or 12 of them a day. I did 5,000 of them last year. So, but MedPage Today just had an article on marijuana use. You know how there's so much propaganda out there about marijuana, but they're showing that people who are over 30, if you use marijuana, you have 4 times greater risk of having a fatal stroke. You know what it does to your blood pressure? Doubles your blood pressure. You know, so and doubles and increases your heart rate. This stuff here really increases your heart rate. Again, it's reportedly 4 times the potency of methylphenidate or Ritalin. Okay, and some studies and some side chain manipulations are as much as 100 times more powerful than Ritalin and marijuana. And so, in answer to the question, how much is a normal dose? I don't know. I don't want to find out. You know. There isn't any normal dose. This, you know, what this does, and they did this when they were studying MDMA, methylene dioxymethylamphetamine. They found that when they looked at the nerve cells, at the cells in the brain, okay, there's little organelles in there that make serotonin and norepinephrine and dopamine, and those cells can be permanently damaged by the use of this. Permanently damaged. In other words, you're not just getting high for the moment. You're killing the ability of the cell to make a normal amount of that dopamine, serotonin, norepinephrine, or GABA. Forever. People go into permanent psychosis from this. They don't come back. You know? See, this is the same thing problem I get into with people who say, well, it's my body, I'm going to make the decision about it. Well, you know, if you permanently damage yourself, who's going to take care of you for the next 30 or 40 years? Who's going to pay for that? Are you? No, we all do, you know? So it's not just your choice, is it? One of the arguments. Anybody want to still use this stuff? See, I have a feeling, so what's the answer to this, okay? The answer is education. The answer is, you know, I'm a doctor, MD, I'm a medical doctor. Doctor, it means teacher in Greek. That's what I do, teach people, you know? If you could walk in my shoes and see, you know, this in the emergency room or the, you know, or the subacute unit, you wouldn't do it. You would say, that scares me. So we need to stop pulling the curtain around these people that are in status epilepticus, another thing that it causes, seizures, bad ones, that you can't stop, okay? Status epilepticus, we need to show people, we need to say, the guy that thinks it's cute or to use this and it's cool and let's experiment and whatever, he needs to see the guy having the seizure and say, I don't want to do that, I don't want to ruin myself for the rest of my life. We need to make this, expose this. Question? Questions? Yes, sir.
I just have a comment. I had a client, it's been about a year, 16-year-old, parents called me and said, we found this stuff called bath salts, and I said, whatever you can do, do not even let him try it once. And they called me a week later, he smoked it once, and it's been a year and he's still in active psychosis in a mental institution.
Yeah. I had a case of a guy that was in status epilepticus, and I went in to see him, and we couldn't stop the seizure. We had to actually put him in general anesthesia, and he woke up the next day like this. He'll be like that for the rest of his life. One time. Yeah.
When you talk about the permanent damage that's done to the cell, and the inability for the cells to produce, the appropriate neurotransmitters, how do we instill hope in the situation in terms of the concept of cognitive rehabilitation of any kind? In terms of
That's a good question.
brain wellness and
Remember, I'm talking about the severe. Okay, I see the severe stuff. Subclinical stuff we don't notice so much. Okay, but there's nothing we can do to go back and change history. All we can do is what we can do, and that means don't use it anymore, and let's get as good as we can get now. Let's protect as many brain cells that are left. See, this kills brain cells. You guys know about brain cells. Brain cells grow back, right?
No.
You get as many as you're going to get the day you're born. It's downhill from there.
that's for sure.
Brain cells don't grow back. What grows in their place? Connective tissue, scar tissue. Does it transmit and think? And no, it doesn't. It's a scar.
It's dead.
It's dead. It does not. It's not dead, but it's not functional. It's just a scar. It doesn't work the same. That's why you have to protect. Muscle is the same way. If you kill a muscle cell, it doesn't grow back. It fills in with connective tissue. That's why you want to not have the first heart attack, not have the first stroke. Because when those cells die, they don't grow back. When you do this substance, it kills brain cells in mass, a whole bunch of them, and they don't grow back. And so are you going to run out of them quicker than the person that didn't do that? Yeah. Increase, the studies, I'm sure the studies show that people who do, cocaine and do amphetamines and this is that they have increased and much increased risk of development of dementia, early dementia, because it kills brain cells, And this is a dangerous substance. It should not be used by humans. This is not to be used by humans. And it says right on the package, not for human consumption. They don't agree with that. Oh, I'll do it and I'll see what happens. Not worth the risk. Yes?
Is the main difference between spice and the bath salts the addition of MDMA to the bath salt?
Spice is bath salts.
It's all the same.
Yeah, spice and bath salts, the names get really real muddled. It depends on who, and you don't even know what you're getting most of the time. I mean, they did studies where they analyze the stuff that's in, that they're selling as bath salts or black mamba or white snow or ivory, whatever, and it's not the same. It's mixed with caffeine, with all kinds of phenylephrine. It's all mixed up. You were shaking your head.
They're different.
Bath salts and
K2 spice. K2 spice was developed by Clemson researchers
Right.
as an alternative to marijuana for cancer patients.
Right.
And they've said that it shouldn't be used, but the what do you call it? The bath salts are more of an amphetamine-like drug.
Yeah.
They're a separate drug. K2 spice is what you're finding on the incense. It's sprayed on there. And they did issue a DEA ban on it, but they did exactly what these guys are doing and changed one.
Right, they changed the site. What they do is they call it cogen or a side chain
Yeah,
manipulation.
they had it changed the day before the FDA ban started, so it never came off the shelves.
This doesn't just happen illegally. The drug companies do this too, don't they?
Yeah.
Yeah, you know Lexapro, escitalopram is citalopram. It's the racemic mixture when they take the dextro rotatory form of it out, so they just have the levo rotatory form. It's the levo rotatory form of the molecule. It's the same substance, just the levo rotatory form. And guess what? They get a new patent on it. It's not the same drug, and they sell it for 5 times the price. The same thing. They've done it with desvenlafaxine. what the effects are. They've done it with bupropion. They do it with a lot of drugs. They just do a side chain manipulation. It's different. They run it through the FDA. Yes?
What would you say about the Rockstar and 5-hour drinks and the
Not,
Red Bull?
they're already in there. Believe me, there are things in the works now. They've had some deaths, and there are things in the works. These are what they call sympathiomimetic amines. Sympathiomimetic amines. Okay. Basically, these are amphetamine-like substances. What these drugs do is increase the cell's production of dopamine, serotonin, norepinephrine, and inhibit the reabsorption of it, so it stays out there for a long time. It causes increase. You know the thing that really scares me, and you've seen some deaths on this. We've seen some. We've already had some. Basically, what will happen is, I've seen this. You go right down here to the high school and watch the kids right before the football game or the basketball game, and they'll pound, 2 or 3 Rockstars or Monster drinks. What do you think that's doing to their heart rate? Now they go out and they work really hard. What happens to their heart rate? It goes way, way up, right? Up even higher. You get up high enough, and we have a phenomenon called R-on-T phenomenon. You know what R-on-T is? That's when the electrical impulse falls in the wrong spot. See, there's a normal rhythm of electrical impulse that goes through the heart. When it falls on the wrong spot, when it gets mixed up, it causes the heart to just fibrillate. And it's not pumping the blood. And you die, Some people say you're lucky if you die. If you don't die, you get permanent brain damage. The worst thing that can happen to you with these drugs is not that you die. Yes?
Just saying that in San Juan Capistrano, we have some kids that we've been working with, and there's 2 head shops there. They're tobacco stores. They're the cheap tobacco stores, Indian tobacco or something. And they sell all this. And I went in with one of the clients and took pictures of it, put it on my blog. And, but the kids, like we had one kid who jumped in somebody's window and they shot him in the night, and he's dead. He was 26. We have a girl who's schizophrenic, and she is using whatever, bath salts or whatever, and she has had her attention span go down to nothing.
Right.
I mean, she can't tolerate, she can't sit in groups,
Right.
she can't listen to you. It's gone.
Yeah.
And it was never good, and it's gone.
These drugs decrease inhibition. That's why they're so dangerous. Normally, the cells that are responsible for inhibiting you, these cells are targeted by this stuff. And what happens is it anesthetizes them for a little bit so that they're not working. So that normally the inhibitions that you have aren't there anymore. And you will do things that are just completely, to the normal person, crazy. Like eating somebody's face off, doing the zombie thing, It's because these drugs are extremely powerful inhibitors of inhibition. Yeah, very interesting. And they don't come back. Sometimes they don't change. They don't come back. Yes?
So a few minutes ago, you were talking about the subclinical clients. And
Right.
I had seen an adolescent male who had used spice once, and the parents had brought him in for counseling. And his problems had to do with anxiety and paranoia. So when we see that kind of a client, then what kind of interventions do you recommend?
Well, that's when they need to see a psychiatrist. That's when they need to have, maybe some medical intervention.
That's
Because
what I
there
was
are some medications that can help this. Although, it's so new, we don't have the therapeutic strategies yet. But sometimes certain medications, can help. The interesting thing too is, like LSD, you can have flashbacks on this stuff. So in fact, there was a kid in Illinois. His father was a doctor, and he used this and became psychotic. And they calmed him down, and they got into the emergency room, and he calmed him down with the benzodiazepine. And he went home and had another episode at home and shot himself. Yeah.
So you're saying that he might have to go on psych meds?
Maybe, depends. That's
Really,
sad.
what do we do with them?
What do we do with them?
Yeah, really, well, I mean, what are we supposed to do?
Well, the same thing that we do with anybody that's psychotic, you know, we treat them symptomatically, you know, we first of all, you know, the first thing you do when you're in the bottom of a hole is you stop digging, right? You don't use it anymore. And you educate, you know, that this isn't the way to, you know, the thing to use. And then you go at the symptoms and you do supportive therapy and, you know, and interventional therapy and medication management if necessary, long-term therapy. Other questions? Did you learn something?
Yes.
Yes.
This is pretty dangerous stuff. And this stuff scares me because, you know, there could be people driving on the freeway behind you like this or, you know, I mean, there's just no, these people have no inhibition. You know, and the thing is, it's getting worse. This isn't getting better. This is growing. This is killing thousands, literally thousands of people in the United States and more and more and more. And there's no way to stop it. Every time we find it and we make it illegal, they make something different that's not illegal. We've got to work on, and again, this goes back to the social psychological side of it. We got to work on the consumption side, don't we?
Absolutely.
Yeah, I mean, you know, we can complain all day about the drugs that are coming in from here and, you know, the drugs that are over there, but, you know, if there's no market for it, that's going to stop. We have to stop the consumption. We have to teach people that this is dangerous and that this is not the way to go, that this causes permanent damage, okay? So, remember that as you go along. Yes, ma'am.
So if we're not able to find it in drug testing, how do they know when someone dies from it? Is it just...
Well, you know, if you do intent, it's not picked up on a routine screen. In other words, if the person tells you, or if they're suspicious of it, then they can go in and you know and do the more technical breakdowns of the, you know, more technical spectrophotometric issue, you know, ways of looking at it.
Our lab, we do test for bath salts and spice, but like you're saying, there's so many different strands. We test for the most common, like JWH 018, 073.
018, 073. JWH was the guy from Cornell that actually isolated the thing, and it is a methylene. It is related. It is a methylamphetamine.
So it is testable, but there are many strands of it. So.
And every time they find a new one and they say this is illegal, they make a new one. Somebody makes a new one, and you don't have to be much of a chemist to do this. I mean, even my 30-year-old organic chemistry, I could do this, you know, easily. You know, you don't have to be much. You make it in the bathtub, and is it real pure then? No. You wouldn't take this. You know, the thing is, if I came into a group of kids and I said, and I do this all the time at the Red Ribbon meeting, I said, I got a drug here, I have no idea what it does. You know, it could be really dangerous. I don't know what the side effects are, the long-term effects. Can I give that to you? And 90% of them will say, no way. But 10% of them will say, yeah, I'll try that. Those are who we got to talk to.
Well, the 90% are lying, though.
Yeah. Okay, other questions?
Just a real quick question. I just want clarity on the difference between spice and bath salts. But I've seen spice and it looks like marijuana. It comes like a silver package.
It doesn't look like anything.
But are they basically similar in chemical structure
Yes.
and results, but just different?
Again, these are not official names. It's like these are not official names. These are street names. These are something just somebody thought up to say, hey, let's put a bunch of this stuff together and we'll call it this. There's no official. You don't know what you're getting. Half the time when you buy drugs on the street, you're not getting what you buy on the street. It's just whatever it happens to be. You know?
Okay, thank you.
So it's a crapshoot. You're getting whatever that happens to be there. It's not, you know, the FDA or the, you know, whatever isn't monitoring that. It could be anything. And could be real dangerous, and usually is. I wouldn't do it. Okay. All right, good job. Excellent questions, too.
Thank you.
Well, that was going to be
I didn't want to do the conversation.